Mic 2, mic 2. Check 1, 2, 3.
somewhat close.
second. Hang on.
Good morning, everyone. Welcome. We are very excited to have you here. We're getting ready to get started. I do see that the auditorium is starting to fill up. We also would like to welcome the virtual audience as well. So here again, everyone, we are here to attend the CMS 2013 Medicare Advantage and Prescription Drug Plan Fall Conference webcast. We're also broadcasting live from our auditorium here at CMS in Baltimore, Maryland, to, again, a population nationwide. My name is Althea Skirvin, and I'm with Provider Resources, and I will be your moderator for the duration of today's event. We currently have probably about approximately 1,700 virtual participants logging on and joining us today in our auditorium. As we begin to actually fill up, we're expecting probably about 175 participants. Of those participants, we have also extended our invitation and also welcome plan organizations who are here to join us, and we're excited to have you here. Thank you for making the trip out to be with us today. I'd like to just run through just a few logistic elements for you. Primarily, just to let you know, again, our webcast and event covers, again, all regions. So again, also out to the regions within CMS, we welcome you as well. In addition to that, we do have some event materials that are available for you. Should you have any issues during the event itself, please feel free to log on to this particular link that's listed behind me. And again, you can obtain copies of the presentations to follow along as well. Questions in particular, we are looking forward to having everyone sort of participate, and we're eager to address your questions as they come up. We do ask, however, for the virtual participants, if you can, please submit your questions via the cto@cms.hhs.gov email address. That's the way in which we will be able to receive your questions. We do also ask that you also identify the topic or session along with possibly the speaker so that we can route your questions very quickly to get the appropriate answer. In addition to that, for our in-person audience here live in the auditorium, we do ask that you, again, address your questions using the mic that's located in the center of the room. This way, all of us, along with our virtual participants, will be able to hear the question as well. Thank you. As part of the efforts for CMS to go green, again, we've basically posted all of our materials out on the website. We do have a website where materials are located. Again, it's located behind me. At the conclusion of the event, we will be asking that you take the time to give us your feedback. It is very important to us. That's our way of continuously striving to improve and give you the proper and more endearing event going forward. We do ask that you take the time to complete the online survey that, again, will be submitted via email at the conclusion of the event. And finally, we will have support for those who are having any technical difficulties. There is an email support box set up specifically to support you in those needs. We do ask that you route your, again, issues, whether you're having issues logging on or any of those issues with the webcast player. Please use the email box located behind me, ctotechsupport@cms.hhs.gov. For the webcast viewers, real quickly, be mindful that your player may look small temporarily. You do have the option to enlarge that to a full screen mode so you can get the full view of our content and presenters today. By using the arrow in the lower right-hand corner in the up and down, you'll be able to toggle back and forth between the full screen mode. We do hope you're able to utilize that well throughout the day. So let's go ahead and get started. Our first presenter, Dr. Cynthia Tudor, is here to join us today. She is the Director of the Medicare Drug Benefit and C&D Data Group at CMS and is responsible for most of the activities related to the implementation and operation of the Drug Benefit Part D for CMS, including Coverage Gap Discount Program. Dr. Tudor's Part D operational responsibilities also include applications, formulary development, contracting, day-to-day operations, and benefits policy. She's responsible for developing and analyzing Medicare Advantage Part C and Part D data and development of performance and quality metrics. Ladies and gentlemen, without further ado, please welcome to the stage our keynote speaker for today's event, Dr. Cynthia Tudor.
Okay. Good morning. I have a lot of sympathy for everyone on the West Coast. I'm hoping they're missing this and they're still snoring, but, you know, we shall see. So welcome to CMS. We're very glad to have you here. If you have come in from outside, we understand traffic is awful this morning. As you have seen in your welcome letter, the Center for Medicare remains committed to expanding the Medicare Advantage and prescription drug plan programs in an effective and an efficient manner. We want to ensure that beneficiaries continue to find value and to understand the choice of plans and their associated benefits. Our 4 strategic goals, which reach across the Centers for Medicare and Medicaid Services, are as follows: better care and lower costs, prevention and population health, expanded health coverage, and enterprise excellence. I think throughout the conference you'll see examples of this as we reflect in our Part D and Part C benefits and policy. We have a lot of accomplishments that I want to go over, and they touch on many of the goals of our strategic plan. We have improved transparency with Medicare Advantage organizations by publishing requirements and providing access to necessary tools prior to bid submission. As a result, we saw an improvement in the quality of the bid submissions sent to us this past June. We implemented a revised formulary submission deadline, and that resulted in CMS having to review only those formularies that were actually attached to Part D bids. While there were operational challenges in implementing this new deadline, we successfully reviewed the formularies in the narrow timelines that were available to us. The MA and Part D programs have established bright, clear lines that distinguish poor performers from the rest of the industry. We've developed and applied consistent methodologies across the hundreds of contracts that we manage, making for easy and fair comparison among our plans. We've also made huge strides in our transparency this past year. We requested comments on virtually every major policy or methodology that we developed, releasing them, publishing more results on our website, like our audit and past performance findings, and including more explanatory language in our compliance letters. We've come a long way since the days of Medicare Advantage and Part D when they first started, focusing our efforts on operational, process, and quality measurements to advance the industry. We've increased collaboration between CMS, the plans, and the states in offering dual special needs plans that meet the requirements of the Medicare Improvement for Patients and Providers Act of 2008, also called MIPA. Under MIPA requirements, dual SNPs must contract with their state Medicaid agency and therefore afford beneficiaries with integrated and better coordinated care. On August the 13th, via our Health Plan Management System, or HPMS, we issued the Integrated Denial Notice, which is also called the IDN, as part of an ongoing effort to streamline appeals notice requirements. This Notice of Denial and Appeal Rights consolidates Medicare Advantage coverage and payment denial notices. It also integrates, where applicable, Medicaid appeal rights information. We've continued our marketing surveillance, which has resulted in a decrease in the frequency and seriousness of deficiencies and up-to-date information for our beneficiaries. We've improved managed care and quality through rational benefit design, case management, models of care, and supplemental benefits such as web-based technologies and enhanced disease management. We have reviewed and approved more than 1,800 required CCIP and quality improvement project plans that were submitted by MAOs last year. These initiatives support broader initiatives in the Department of Health and Human Services that are designed to address both cardiovascular disease and the reduction of 30-day all-cause readmissions. In star ratings, we have redefined the low-performing icon so that we encourage at least a minimal level of performance across both Part C and Part D for MAPD plans. And we've revised the improvement measure to hold contracts harmless if they receive 5 stars in the particular measure for the 2 years being evaluated. We also conducted a webinar on best practices of high-performing plans with the hope of transferring knowledge and practices that other plans that were low-performing could use. And we hope that this assisted the low-performing plans with information to help them get better. We continue to explore additional measures that come from consensus organizations, and we seek stakeholder feedback and look for other available enhancements for our star ratings. The MA and Part D star ratings has been broadly hailed as the best instrument of its kind developed to date and an effective vehicle for aligning plan sponsor interest with the achievement of CMS goals. This is a great honor that we've gotten. The greatest gains that we've seen in the star rating system are for MA plans, suggesting that the pay-for-performance requirements of the ACA is improving care. According to NCQA's 2012 State of Healthcare Quality Report, Medicare plans are the most improved. They hold the largest overall improvements than commercial or Medicaid plans. And I think this coming open enrollment season, you'll continue to see improvements in star ratings for Medicare Advantage and plans. The agency also made broad strides in influencing opioid utilization management. The Medicare Part D Overutilization Monitoring System, which we call OMS, was developed to help us ensure that Medicare Part D sponsors have implemented improved drug utilization controls and case management to assist in preventing overutilization of prescribed medications. Gary Worth will be talking about this more at the 10 o'clock session. The first OMS reports were released in July, and they identified beneficiaries with potential overutilization issues, including opioids. The initial results suggest that our new policy may be helping to reduce the potential of overutilization of opioids and APAP in 2013 in Part D. We also implemented the Encounter Data System to collect, price, store, and process data from MA organizations in order to better analyze beneficiary healthcare encounters. The system went live in 2012 and is currently midway through a great year with many new submitters, end-to-end certification, and processing improvements. We proposed and finalized the medical loss ratio regulations for both MA and Part D, and we hope that this improves the value for our enrollees. We codified the requirements by requiring that MA organizations and sponsors with contracts less than 85% MLR pay a remittance to the Secretary and be subject to additional penalties if low MLRs persist. We also worked with CMS and SSIO to coordinate and align the commercial and Medicare MLR policies. We developed the draft MLR reporting tool and have issued the proposal for public comment as part of the Paperwork Reduction Act. and our first comment period on this will close this month. We updated the CMS HCC risk adjustment model. We revised this model to data used, years used to calibrate the model, and a clinical revision. The diagnoses were included in each HCC. Through our audits and our compliance actions, we've learned a lot about how plans operate, and we've also shared this information with the industry in our most recent best practices and common findings memo. We continue to hold plans accountable for the inappropriate denial of services and medications to beneficiaries through our spectrum of compliance and enforcement actions. While we have numerous stories like this that we could share, and I could go on, we do face a number of challenges, and I just want to talk about that. How do we maintain a robust and vibrant MA and Part D programs in the face of increasing budgetary constraints? Our resources are more limited than in the past, and the demands remain extremely high. We play a large role in the Medicare Medicaid plan administrations, excuse me, where each state has a unique approach. We're supporting the ACOs in a variety of ways, and many staff are helping our colleagues in SCIO launch the exchanges. As we don't have to tell you our budgets are tight across the federal government, yet we remain committed to maintaining and expanding where necessary our monitoring studies, our contractor oversight, and our implementation of new policies. So when you contact us, we ask that you be mindful of these processes and these pressures while we work with you to answer your questions, provide data, and remain as customer-oriented as we can possibly be under these circumstances. We must provide ongoing consideration of creative approaches to enhance care management within the MA program and in turn improve beneficiary health outcomes. We must continue to improve our application process to minimize requests for exceptions to our network requirements. We continue to receive a number of inaccurate submissions of bid components by Part D sponsors, and this includes discrepancy between the formulary and the PBP, discrepancies between the PBP and the BPT, the inaccurate interpretation of our guidance leading to bid submission errors, and gaps in understanding about the various components of the bid and their interdependencies. We want to encourage plans to improve their scores over the next several years and encourage more beneficiaries to enroll in high-quality rather than low-quality plans. In our work with opioids, the challenge is the number of APAP potential overutilizers, which is significantly higher than the opioid overutilizers, and the seriousness of this problem needs more attention. We continue to monitor the impact of this Part D policy on overutilization of medications, and we're pleased with the publicity that the project has received. We've seen unprecedented growth in the enrollment of employer group waiver plans. While not unexpected, we're increasingly hearing complaints from AQIP enrollees about certain beneficiary protections that are missing, and they express a number of other concerns. What this means is that CMS is focusing on AQIPs in a new way, which if it hasn't become evident already, it will become evident as we work on this over the next year. We'll increasingly include AQIPs in our monitoring activities to the extent that they have previously been excluded, and are launching new monitoring activities that are directed especially at them. And much more will come about this in the next month or so. Our plan audits continue to show noncompliance with organizational termination appeals and grievances, which is the Part C side, and coverage of termination appeals and grievances, which is the Part D side rules. Failure to comply with our rules erodes patient protections and creates inefficiencies in the administration of our programs. Our program is improvement-oriented, and we continuously work to redefine the audit process to be more efficient and less burdensome to your organization. We strive to audit all the Part C and D organizations within a reasonable time to protect beneficiaries and the integrity of the program. We're excited about today's agenda and the information that we have to share. Today's presentations will expand our discussion around the topics such as the Part D overutilization monitoring system, MA policy updates, audit updates, and encounter data updates. Again, thank you for joining us today, and have a great conference.
Thank you very much, Dr. Tudor. Our next presenter for the day is Gary Worth. He's a pharmacist in the Medicare Drug Benefit and C&D Data Group, which is the Division of Clinical and Operational Performance. The new Medicare Part D overutilization monitoring system was developed to help CMS ensure that plan sponsors have established appropriate drug utilization management programs to assist in preventing overutilization of prescribed medications. To speak with us today on the subject of overutilization monitoring system, as well as provide us with the updates and lessons learned, please welcome Gary Worth.
Thanks, Al, and good morning, everyone. At the fall conference last year, we described the new Part D opioid policy and heard from sponsors who participated in a pilot of that policy last summer. This presentation today is about the new overutilization monitoring system, not about the overall opioid policy. Today we'll review the background information about some of the requirements to improve drug utilization controls in Part D. We'll also cover the overutilization monitoring system, provide some updates to the OMS, share data from our first reporting cycle and what we learned, and tell you how to access more information and take questions as time allows. The appendix includes a website and report templates, but we aren't going to cover them today. Those slides show examples of the OMS website and reports that are available to Part D sponsors. Now, our work to develop the opioid policy to address overutilization of opioids began in 2011. The policy was fully described in the 2013 final call letter and in supplemental guidance later that year in September. These documents describe the new policy in Medicare Part D requiring sponsors to implement improved drug utilization controls and case management to address potential overutilization of opioids in their prescription drug benefit plans effective January 1st of this year. Continuing with background information, the call letter and September guidance described 3 levels of controls that plan sponsors can implement. The first one, level 1, is improved use of concurrent claim methods, in other words, safety controls at point of sale. We included in that section a reminder that the Part D sponsors are expected to prevent coverage of unsafe daily doses of acetaminophen, that is, doses that exceed the FDA maximum of 4 grams per day. We also thought that since most prescription APAP products are included in opioid analgesics as combination products, better control of APAP usage would also reduce the amount of opioid overutilization. The second level is improved use of formulary management designs, such as quantity limits at point of sale. Part D sponsors may use quantity limits to reduce the use of medication above the FDA maximum dose, such as for APAP. And in cases where there is no maximum dose, you can submit quantity limits below the FDA max, such as for opioid analgesics. The next level, and this was fairly new, the level 3 improved retrospective drug utilization review, programming, and case management. Part D sponsors should look for apparent opioid use that's duplicative over time, over sustained periods of time, and across multiple products and at high doses. CMS developed a methodology that we think identified non-borderline cases of high opioid use for case management and for your review. That was based on morphine equivalent dose exceeding 120 milligrams of morphine equivalent dose for at least 90 consecutive days and from more than 3 prescribers and more than 3 pharmacies. Upon review, clinical staff should be communicating with prescribers to determine medical necessity and also to share information about the existence of multiple prescribers and the beneficiary's total use of opioids. The results of case management should confirm whether the current level of opioids are medically necessary, if a lower level of opioids is medically necessary, or if in fact no opioids are appropriate for this particular beneficiary. Part D sponsors must then determine if an appropriate claim edit for a specific beneficiary should be implemented if the current level of opioids is not confirmed to be medically necessary. Part D sponsors must also provide a 30-day advance written notice to both the beneficiary and to the opioid prescribers of the beneficiary, announcing the pending POS edit with a right of appeal, and to send a copy of that notice to CMS through the policy mailbox. We expected to see implementation of point-of-sale claim edits by the second quarter of this year. We also included in that section a reminder that we will, in fact, monitor the implementation of new opioid policy by Part D sponsors, and now we have the overutilization monitoring system, which we'll talk about today. Now, the overutilization monitoring system, which I'll refer to as OMS, because it's really easier to say, the OMS module was added to the Patient Safety Analysis website, which already uses similar processes to send patient safety measures to Part D sponsors. In the appendix, again, you can view OMS screens that are included in the patient safety website and examples of the reports and response form that are sent to Part D sponsors. Each beneficiary who was identified through OMS is assigned a unique ticket number. That ticket number may include multiple problems. For instance, a beneficiary may be appearing to take too much acetaminophen as well as too much of opioids, as well as be on the CPI referral list. So you could have up to 3 issues for a given beneficiary ticket. For each given beneficiary contract ID combination, only 1 unique ticket is assigned. The response from the plan sponsor is required for each issue on that ticket, not just for the total ticket. What's included? Through OMS, each sponsor has access to contract level reports of beneficiaries who are identified with potential overutilization issues. At this time, those issues are limited to acetaminophen, too much opioids, as well as CPI referrals. Contract and ticket level summary reports are viewed on the Patient Safety Analysis website. A contract summary, beneficiary level reports, and a response form are included in the package of reports that sponsors can download from the Patient Safety Analysis website on a quarterly basis. The first reports were released on July 31st, and the next set of reports will be available at the end of October. The OMS package of reports is available on the last business day of the month following the end of the calendar quarter. An email notice is sent to users when the reports are available for download. OMS users can have 2 different levels of access to the Patient Safety Analysis website. That will be summary level or summary and confidential level access. In order to download, view, and process the OMS package of reports, which contain confidential data, at least 1 user from each contract must have both summary and confidential beneficiary access on the Patient Safety Analysis website. Now, for the review process, after the sponsor receives the email notice that they have some reports available from OMS, they will download reports, they'll investigate the outliers on the reports, complete the response form by selecting the appropriate response code. Again, that list is at the back of the appendix. And then upload the completed response form to the OMS within 30 days through the Secure Upload Files feature. Our overutilization issue types, again, are APAP, opioids, and CPI. For APAP, using PDE claim data, we identified overutilization as beneficiaries who exceed 4 grams a daily dose of APAP for a total of 30 days or more during the 6-month measurement period. That's not consecutive days, that's total days, 30 total days. Beneficiaries who exceed this threshold appear to us to be using excessive amounts of APAP on a chronic basis. For the opioid measure, we defined a narrow target population of potential overutilizers, as I mentioned previously, based on morphine equivalent dose, that if a beneficiary exceeds 120 milligrams morphine equivalent dose for 90 consecutive days and received that medication from more than 3 prescribers and 3 pharmacies, we believe that represents a narrow target group that you can begin the case management approach for opioids. We did expand the measure to include all the beneficiaries' opioids for the OMS system in 2013, not just those from the 120 milligram morphine equivalent dose prescribers. For the opioid measure, we exclude beneficiaries who are in hospice care and also beneficiaries with cancer diagnoses. The cancer diagnoses are pulled from the risk adjustment management system, the risk adjustment processing system, RAPS data set, and the hospice beneficiaries are from the enrollment database. Providers from the same office are not counted as one provider by CMS. We don't have any way to accumulate them but by address, and we'll address that a little bit further on. We also expanded the list of opioid medications as well as revised the conversion factors based upon information received from the Centers for Disease Control and Prevention. In 2011, our product list was based upon information we found in the literature that identified conversion factors for opioids. Fortunately, CDC is now doing that for us and has an extensive list of all the opioids as well as their conversion factors, which we are now relying on for the OMS. Our last issue type are the CPI referrals, and these represent a very small number. Sponsors refer cases of potential fraud and abuse to the medic, who then make referrals to appropriate law enforcement agencies or outside entities. The Medicare Center for Program Integrity will identify those beneficiaries whose cases were declined by OIG or the other entities and subsequently refer them to local law enforcement. We at CMS review these cases, and if it appears that potential misuse of medications is continuing, we include those cases in the OMS for further follow-up and evaluation by plan sponsors in accordance with CMS policies. That is, not every CPI referral gets pushed back out to the plan sponsors. Only the ones, after our clinical review, appear to continue to have a potential misuse problem. So let's talk about some updates to our methodology. I mentioned previously that our overutilization is identified through analysis of PDE data within the OMS measurement period. For the first reports, the analysis covered PDE data from January 1st through June 30th of this year and received by June 30th of this year. That PDE may be incomplete. You can continue providing updates to PDE through June of the following year. Through this 2013 year, we are going to gradually increase the look-back period or the analysis period to a full 12 months. The third quarter reports will be based on PDE from January 1 through September 30. The fourth quarter reports will include all 2013 PDE January 1 through December 31, received by December 31. Those will also be potentially incomplete because PDE can be updated through June, as I said. Now for the APAP measure, we are going to continue to base that on at least 30 days of more than 4 grams per day within any 6-month measurement period within that broader analysis period. That gets a little bit complicated because, as you can imagine, that there are many 6-month periods within a year, up to 185 or so 6-month periods. So we're working on that logic to expand that through the coming reports. The opioid measure will grow to a 9-month look-back measurement period for the October reports, and then 12 months, and continue as a rolling 12-month thereafter. We're going to update the medication list and conversion factors periodically as we identify new products on the market, new generics, and as CDC provides new conversion factors for them. I'd like to mention also that NDCs with obsolete dates more than 1 year before the start of the analysis period are excluded from our analysis. We are investigating methods to identify more current diagnosis data for future reports rather than relying on the data that's in the RAP system. We're planning to increase the OMS functionality. This was also mentioned on the user call last month. Beginning with the next release, our intention is to collect point-of-sale edit information from sponsors, including the notice, implementation, and discontinuation dates. Up until that time, we collect this information by receiving the notice letters in the Part D policy mailbox, and then have to analyze and parse out all that data from each of those letters that we receive. With the next release, we are going to additionally expect sponsors to submit the data, a limited data set, about each of those point-of-sale edit notices to us through the OMS. By collecting it this way, this will help us to exclude beneficiaries for whom a point-of-sale edit has been implemented. We also intend to collect information from sponsors on beneficiaries their system have identified that have not appeared in our reports. So if you've identified an APAP or an opioid overutilizer that we haven't, and you want to tell us about it, we will collect that information. And again, if you submit us the response code that indicates that it's medically necessary or a few others, that will help us to exclude those beneficiaries from future OMS reports. So there's clearly a benefit for the plan sponsors in these updates. And in the future, no timetable and no products identified, we may expand OMS to include other drug classes. As you can see, the system works for APAP, it works for opioids, and clearly would be usable for other kinds of drug classes that may be identified in the future. And now let's look at some of the findings from our 2013 OMS analysis and reports, and we'll compare that to 2011. This first slide shows a pie chart of the contracts with potential overutilization issues of 734 contracts. About 562 Part D contracts had at least one beneficiary with an issue. This is the blue section of the pie representing 77% of those contracts. 172 contracts did not have any issues and also did not receive any OMS reports. This colorful chart is our first comparison of 2011 data, which is a full year's worth of data, to our 6 months of 2013 data. This chart compares the number of Part D enrollees, prescription APAP and opioid users for the full 2011 year and our 6 month in 2013. In 2011, there were nearly 31.5 million beneficiaries through December 31st. And in 2013, there were 36.7 million beneficiaries as of June 30th. That's a significant increase. However, given the increase in Part D enrollment in 2013, one might expect a corresponding increase in the number of APAP and opioid users as compared to 2011. However, this is not yet evident in our aggregate 6 month data. Looking at the blue charts, blue bars, in 2011, there were almost 9.5 million APAP users, that's prescription APAP, and in 2013, there were almost 7.4 million prescription APAP users as of June 30th. Looking over at the red and pink bars, in 2011, there were almost 8.8 million opioid users, and in 2013, in the 6 months, there were about 9 million opioid users as of June 30th. We're going to look at some more granular data in following slides. In 2011, of those 9.5 million APAP users, about 150,000 exceeded our APAP threshold. That is a significant number. That really shows that the overuse of APAP is a significant concern. And 22,000 of beneficiaries in 2011 exceeded our opioid threshold. 150,000 APAP versus 22,000 opioid. Clearly, APAP is a big concern. Let's look at some similar figures for 2013. In our 6 months of 2013, there were 7.4 million APAP users and about 31,000 exceeded our APAP threshold. Remember, we just saw that in all of 2011, there were 150,000 APAP users who exceeded the threshold, and now in the 6th month of 2013, we're down to 7.4 million APAP users. In the first 6 months of 2013, over 4,000 of the opioid users exceeded our opioid threshold, as compared to 22,000 in all of 2011. And about 100 beneficiaries exceeded both APAP and opioid thresholds. I mentioned previously that we exclude beneficiaries with cancer and hospice from the opioid measure. In our 6-month OMS reports, we excluded only 270 beneficiaries. That's a pretty small number. 211 with cancer, 50 with hospice, and 9 with both cancer and hospice. We are, as I stated earlier, investigating sources of more current diagnosis data to apply to the opioid measure, which may kick up those number of exclusions. We also exclude beneficiaries from the reports if we've received notification that one of those beneficiaries has had a POS edit implemented by their Part D sponsor. For the July reports, there were only 2 beneficiaries excluded because of prior point-of-sale edits. Now here's another chart comparing 2011 to 2013. For the July 2013 OMS reports, which is the small circle, we showed considerably fewer potential overutilizers compared with the 12-month findings of 2011, the big circle. In fact, it's about 1/5 as many as the 2011 figures. In 2011, again, there were 150,000 with APAP issues and 22,000 with opioid issues. In the first 6 months of 2013, the OMS identified 35,508 beneficiaries with at least one potential overutilization issue, including 31,245 beneficiaries with APAP issues, 4,351 with potential opioid issues, and only 13 CPI referrals. Even though the July 2013 results only cover part of the time period compared to 2011, we don't anticipate having nearly as many beneficiaries identified as overutilizers compared to 2011. However, a direct comparison is limited by several factors, which we're going to talk about in the following slides. The first factor is the measurement period. I've said this several times already. The 2011 data covered complete PDE data for an entire year, whereas the 2013 analysis only included incomplete PDE for the first 6 months of 2013. The second factor, which is significant, is the change in provider identifiers in 2013. Beginning in 2013, all prescription claims must include the prescriber's National Provider Identifier, the NPI. However, in 2011, where we did our other analysis, prescription claims included DEA numbers, NPIs, and other kinds of identifiers. Although we attempted to crosswalk them and take care of any miscounting, it's quite likely that the multiple kinds of provider identifiers contributed to overcounting or double counting of prescribers, and therefore higher numbers of opioid overutilizers in 2011 compared to 2013. If you think about it, if a beneficiary's limit of providers is no more than 3 prescribers, so if a beneficiary went to 3 doctors and got their opioid prescriptions, and only one of those had claims where the pharmacy once submitted a DEA and once submitted an NPI, that would kick that beneficiary over into the exceeded the threshold category. So we can't really determine the significance of it, but it seems logically that that would be an important factor. Another limitation is the source of diagnosis data. We use the data from the prescription drug hierarchical condition categories, RxHCCs, from the risk adjustment processing system. This information is not based on current diagnoses and will not identify beneficiaries who are newly diagnosed with cancer or are new beneficiaries who recently enrolled, which may contribute to false positives. Also, a beneficiary who no longer is actively being treated for cancer and may be cured may be excluded from the opioid measure because it's sticky in the RxHCCs. So we are looking for a better source of this data. Finally, our last factor is a change in our morphine equivalent dose methodology. As I mentioned, the CDC provided a comprehensive list of opioid medications, and their methodology includes all the opioids, not just those related to pain. So it would include cough products and other kinds of opioid medications on prescription. And they also use a slightly modified conversion factors, particularly for the fentanyl patches and other fentanyl products. So our methodology was modified to incorporate the CDC conversion factors as well as the products. Since the list of opioid products was much broader, you would expect that would increase the number of potential outliers of opioids. These conversion factors and medication lists are included in the user guide that's available on the Patient Safety Analysis website. Here's some more information about what we learned from our OMS July reports. If you look at the columns here, we're comparing the MAPDs versus the PDP percentages of enrollees versus their overutilization issues. If you look at the column that include the percents, Part D enrollees in MAPD, MAPDs had 36% of the enrollees, and PDPs had about 64%. If you look at the percent of APAP overutilizers, that's about the same as the enrollment in MAPDs and PDPs, 36 and about 64%. But if you look at the potential opioid overutilizers, the MAPDs only had about 23% of the opioid outliers, whereas the PDPs had more than 76%, a significant higher of opioid potential overutilizers. We can speculate on the reasons for that. We might say, gosh, the MAPDs are better able to manage opioid use because they have the relations with the physicians, or perhaps because the PDPs have the much larger percentage of LIS and other beneficiaries who take opioids. And there are other factors. We just don't know the reasons for sure, and I'm just speculating. You can probably think of some other possible reasons why that could be true. This slide, we look at the LIS status of beneficiaries from our July OMS reports. The OMS reports here, if you look at the blue bars, they represent the low-income subsidy beneficiaries. They represent who are 32% of the Part D enrollees. But 52% of the APAP potential outliers, and 83.5% of the potential opioid outliers. Pretty significant difference. We also looked at the disability status. The disabled status here are in the orangish bars on the chart. The disabled represent 20% or so of Part D enrollees, but 50% of the potential APAP outliers and 91% of the potential opioid outliers. And it kind of makes sense that if you're disabled, you're taking a lot of pain medications. And this one, we looked at age, the age of the beneficiary compared to their APAP and opioid use. Those under age 65 are in the green chart, green bars. They represent about 19% of Part D enrollees are under age 65. However, that group represents about 45.5% of the APAP outliers and almost 90% of the opioid outliers. We also identified that a certain number of beneficiaries changed plans during their period of overutilization. We include on our OMS detail reports an indicator if the PDE that contributed to the overutilization measure included a PDE from a prior contract. In other words, the beneficiary, for some reason, changed contracts during their period of overutilization. We do not identify the beneficiary's prior contract on those reports. All we can tell the sponsors is, in fact, that it was from another contract as well. In fact, we have had a few questions come in where a sponsor says, you sent me this list, but I don't see any claims for this beneficiary in my data. Well, they were flagged as being from a prior contract's data. We are not trying to infer that beneficiaries change plans due to overutilization. In fact, here we just describe on this screen a number of reasons why beneficiaries may have changed their plan during the first 6 months of this year. This isn't scientific. We didn't measure this. These are just some of the reasons, such as to enroll in a 5-star plan. There are various special enrollment periods, such as if someone moves, their current plan is no longer available, they lose or gain special eligibility, or for the dual eligibles or LIS beneficiaries, they can change any time. There are other reasons why people can change plans. Beginning with the April 2014 reports, OMS will also include beneficiaries who may have switched plans during the annual open enrollment period. Additionally, something we've seen through September 3rd, 2013, this is the latest data. Now, for the entire year of 2013, as I mentioned, Part D sponsors are supposed to implement point-of-sale edit controls if a beneficiary's usage is not deemed medically necessary. And we expected this to start by the second quarter of this year. Well, through September 3rd, we received notice of opioid point-of-sale edits for only 147 beneficiaries. 45 of them were the PS1 class, that is, no drugs in the class are allowed, and 102 where one or more drugs in the class are allowed. We also identified that 11 beneficiaries who received notification of point-of-sale edits did in fact switch plans. And as I previously mentioned, 2 of these 147 beneficiaries were excluded from our OMS reports because they had these edits. I'd like to share with you now some new data from analysis of all the responses the Part D sponsors sent in at the end of the month. We just got this yesterday, so there's no slide. You have to listen closely. First of all, great job to Part D sponsors for how they manage the OMS reports and their responses. 99.5% of all the ticket issues were submitted on time to CMS through the OMS system. 99.5%, that's fantastic. There's a very small number where the tickets were not submitted properly or on time. We also expected a very large percentage of responses that said, our investigation is not complete. You essentially have 30 days to figure out how to do it, understand the OMS system, and then investigate your beneficiaries and send a response. So we expected a large percentage of INC responses, meaning we haven't finished our investigation. Surprisingly, only 35% of the responses were incomplete. So the Part D sponsors really did their work to try to sort this out when they received these reports. Surprisingly to us, we received over 6,000 responses that a POS edit was determined necessary. So we've received 147 responses so far this year. So that suggests that within the next month or so, our Part D policy mailbox is going to receive 6,000 more notices of point-of-sale edits, that's just amazing. So we're really wondering if when Part D sponsors submitted these responses, PS1 and PS2 in particular, if they really meant a beneficiary-specific point-of-sale edits, or if they were thinking this applied to their broader-based DOR claims edit based upon 4 grams of APAP, or some other kind of perspective or plan or a consideration of what that PS2 meant. Most of those were in fact for APAP. So we're not sure what it means, and I'm hoping that perhaps during this session someone will step up and not ask the question, but will provide us the feedback that says, this is what we thought it meant. Otherwise, we might have to beef up our staff who are managing their Part D policy mailbox real fast to get all these letters and to review them and analyze them, and then post them into the OMS. So that concludes the sort of the didactic part of the presentation. I'm going to cover a few of the fundamental questions that came in to the Part D policy mailbox. The first one is here: does the CMS methodology take into account whether providers are from the same office or pharmacies are within the same chain. And I already mentioned, no, we don't do that with providers, and we also don't do that with pharmacies. We cannot aggregate them into a particular office, location, institution, or company. We think that being associated with the same practice does not automatically mean that the providers are coordinating care for the patient or sharing electronic records or viewing and responding to the same internal clinical alerts. Having said that, it is quite possible that a Part D sponsor in their internal criteria includes certain information about group practices that CMS doesn't have, and that's okay. Question number 2, does CMS methodology for APAP or opioids take into consideration early refills of subsequent prescriptions, because that creates a quantity overlap? And we do not specifically adjust for early refills in our measures. We believe the criteria takes into consideration a reasonable, suitable number of days that can be attributed to appropriate early refills. We are concerned about the potential for overutilization during the early refill period and the history of continuous early refills for some beneficiaries. We intend to monitor the OMS to assure whether our criteria is appropriate and then make revisions as necessary. We will appreciate your suggestion and feedback about any of our measures, about the methodology, things that you've seen. In fact, during this session, if you want to step up and provide feedback, we appreciate that as well. We mentioned during the presentation on the user group call that NDC level medication lists would be available for the opioids and the APAP measures. The medication lists are not listed by NDC, and will we provide that information by NDC? And the fact is, no, we cannot release NDC list to you due to some licensing restrictions. We used Medicare and First Data Bank to develop those NDC lists, and those complete lists of medications are available on the Patient Safety Analysis website. A Part D sponsor or their representative could certainly generate complete NDC medication list using their drug files, just as we did by identifying what are some common factors across all opioids or acetaminophen products, and then compiling them and developing the NDC list themselves. But we cannot provide those lists. What do you mean by exempt diagnosis when one of the response codes, that is, the beneficiary has an exempt diagnosis? Well, what we mean by that is that for the purpose of reviewing a particular beneficiary's case, each Part D sponsor sets up their own criteria, and their criteria may in fact include exempt diagnoses. CMS used exempt cancer diagnoses based upon the 4 RxHCCs in our methodology. But for this particular response code, we're not referring to our exempt diagnoses, although we would recommend them. We are really referring to the Part D sponsor's own criteria and the exempt diagnoses within their criteria. Our last question that came in from the policy mailbox for this meeting is on the OMS report response file. We noticed that the stated responses appear appropriate for opioids, but not necessary for APAP. How do we respond if none of the codes seem to fit? Well, at this point, all the responses are in, so you've already selected the most appropriate code available based upon your understanding of the OMS response codes. Based on our review of questions that we received in the Part D policy mailbox, we think that the majority of those codes do in fact apply to APAP as well, particularly when you consider a Part D sponsor can have their own internal criteria, including early refills, multiple providers, and other kinds of situations. However, we are evaluating the response codes and considering adding additional APAP level response codes. And so again, we would appreciate any suggestions you have or feedback about the OMS as well as response codes, or what you didn't understand, what we need to clarify in the user guide for the October release, and so forth. Now, additional information about the OMS is available on the Patient Safety Analysis website under the Help Documents section. That includes the user guide as well as the medication list. If you need help accessing the OMS package, or you have technical questions about the patient safety analysis website and how OMS works, you can contact Acumen, the contractor, by email as indicated on the screen, or call them by telephone. They are happy to help you. And they also let us know as well so that we can get updates about what are the current issues. You can also send a question to CMS. We are receiving all the questions through the Part D policy mailbox. We ask that if your question is about the OMS system itself, that you would include OMS in the subject line. And if your question is about Part D opioid policy, you include overutilization policy in the subject line. There are more than one person who are trying to review all the incoming questions, and one person looks at the OMS technical questions and another person looks at policy questions. So that will help us if you can do that. Additional information about the OMS is available on the CMS website, and also about improving drug utilization review controls in Part D. The website link is there. We call that the Improving Drug Utilization Review Controls in Part D. It includes excerpts from the call letter, the September guidance, and much additional information to help Part D sponsors to create or change their programs to address unsafe use of opioid pain medications. Now we have a few more minutes, so we'll take some questions as time permits, and also, again, please feel free to use the time to provide us feedback or suggestions about OMS. Questions? Come up to the mic, please.
My name is Brian Du from the Medicaid. I have three small questions. First one, your total IPAP dose includes OTC or not? That's the first question.
I'm sorry, just one at a time. Could you say that again for me?
Your total dose, you control the total dose is 4 grams.
Right.
For 30 days. This includes OTC or not?
No, the APAP measure is based upon PDE, and so we only receive claims for legend drugs, prescription drugs. So we do not include over-the-counter APAP. So that's a significant additional risk for beneficiaries who are already taking too much of the prescription product.
Great, thanks. The second question is for the prescriber, the more than 3. There's any prescription is a high, prescription for identification ID, the same ID, your very high prescription, include in your messenger or not? Because we finding some prescriber like over 1,000 per benefit carrier. That's very strange. But some data show that. Any case to CPI for continued investigation? For opioid?
For opioids?
Mm-hmm.
Right now we don't do anything for education or identifying opioid overprescribers, if that's what you're asking me.
Yeah.
We're leaving that to Part D sponsors. We have the ability to run those kind of reports, but we are not currently flagging the prescribers who may be the sources of the excess number of opioid prescriptions. It's possible we could use that in OMS in the future, but that's not something we're planning right now.
Okay. Any case you're finding that the ID stolen by some criminal, because such as some very high prescription for some ID.
We're not aware of that. It's not something we're looking at.
Okay.
During the pilot last year, we heard a couple cases where the beneficiaries who were overutilizers claimed that their ID had been stolen, but Part D sponsors still had to deal with that as well.
Okay. The third question, you said you will in future and the other drug in your OMS messenger. You think about the psychotropic drug or any other drug you will plan and in the future?
Now, we haven't identified classes of drugs. You can speculate that we all know of a number of classes that are of concern. I think there was a question for the call letter where we asked about other classes of medications for the opioid or the case management process. There wasn't any clear indication of where we should go. So today, we don't have a particular class. I just included here so that you know it's potentially can be used for that. And as I said, we could use it for prescribers. It could be used for lots of different communications to plan sponsors.
Sure, thanks, because you are a great job. We just want to learn. Thank you.
Thank you. Any other questions?
Hi, thank you for the data. Very interesting. My name is Michelle Johansson. I'm from PerformerX, and I have a question about adding additional classes or additional drugs in case management. Is CMS going to consider revising the actual MTM program? Because a lot of the resources that are being put into this particular opioid management process are the same resources that, at least from our perspective, we're using in MTM, and there's at least, I guess what you would call a greater return on investment in having it in MTM. Is there any thought about combining those two or waiting to add drug classes to a moment when MTM can actually truly encompass all case management expectations?
Well, that sounds like a great question as well as a great suggestion. This is really about OMS, not MTM, but I'll mention that we did add another core condition category, not core condition, another category in the MTM submission for chronic pain. That's what we've done so far, but we agree that the MTM program would be a reasonable mechanism to try to address these kind of issues. Other than that, we don't have any plans today to do more with that.
All right, thank you.
But thanks for the suggestion.
Thank you.
Any other questions?
Good morning, Krista Fagan, also from PerformerX. I have two questions. So you talked about how 6,000 of the responses thought the POS edit was determined necessary, and that you're unclear if they actually meant the more general drug utilization edit or the actual beneficiary level edit. Just to confirm, the responses should be based on the beneficiary level edit. Is that correct?
Those two codes, the PS1 and PS2, are intended to be for beneficiary-specific point-of-sale edits, not intended for global edits that you put in place. We recognize that maybe that wasn't clear to everyone, and we're going to provide more explanations in the next release of the user guide to clarify that, and some of the other codes as well, because we're trying to evaluate the response codes and appreciate your feedback as well.
Okay, thank you. And my second question also has to do with the response codes. So we already talked about how the outliers do not account for overlaps due to the early refills. What would your recommendation be for a response to that? In other words, what should the response code be if we find that to be the case?
We don't want to evaluate each sponsor's case situation. However, if in fact, I tried to allude to this a little bit earlier, if in fact your internal case management criteria includes evaluation and acknowledges early refills, early appropriate refills, then selecting the one that says does not meet our internal criteria may be appropriate for you. But then again, that's sponsor specific, and I don't want to, lead anyone down a path.
Thank you.
Looks like I'm done. Thank you all.
Thank you, everyone, and we do also appreciate those wonderful questions that were actually raised this morning. We're going to go ahead and move on to our next session. We have two ladies who are actually going to be joining us to talk to us about marketing and surveillance updates. From the Division of Surveillance and Compliance and Marketing, Medicare Drug and Health Plan Contract Group, we have Camille Brown and Christine Reinhardt. The Division of Surveillance, Compliance, and Marketing is responsible for secret shopping and compliance activities, as well as marketing issues related to the Medicare Advantage organizations. Camille Brown has been involved in several key agency initiatives, which have included the development of the Medicare marketing guidelines and the development of regulatory marketing provisions for Medicare Advantage and Part D plans. Ladies and gentlemen, please welcome to the stage Camille Brown and Christine Reinhardt. Thank you.
Good morning, and again, welcome. So this morning we have a couple of things on the agenda, and we want to provide you with some updates, some clarifications, some things that will help you stay in compliance as you prepare yourself for the 2014 marketing season. So you've had the marketing guidelines released to you, you've had the training, we've also provided you with an PMS memo that provides you with some additional clarifications. Those are the tools that you should actually be using again as you prepare for the upcoming marketing season. Our goal here today is really to provide you with as much information as possible so that when you're conducting your activities, you're providing beneficiaries with clear and accurate information. So you'll see on the slides that we're going to provide you with some guiding principles, and I'll talk about those briefly on the next slides. Those are the 3 guiding principles that you should be utilizing as you conduct your marketing practices for 2014. I'll provide you with some marketing clarifications. Each year, we get questions in about what activities may be performed prior to the October 1st date. So I'm going to provide you with some information on that as well. We'll talk about some website requirements and what needs to stay for 2013 and what plans should be looking at for 2014. Last year, we had a lot of questions and feedback with regards to star ratings, how plan sponsors may actually provide information to beneficiary on star ratings. So we're going to talk about that a little bit. We'll provide you some information on the ANOC EOC as it relates to the timeliness of ANOC EOCs, meaning are they being sent out as specified by CMS. We'll talk about the accuracy of the ANOCs, EOCs, as well as what we've seen through our assessment this year. We'll also provide you with some information on agent broker oversight, and we'll provide you with some detailed guidance on the compensation requirements as it relates to payments. In addition to that, we have conducted an analysis on the OEV requirements, so we want to share some information with you on what we found through those findings. And lastly, we've conducted some retrospective reviews on the ANOC EOC, so we're going to share with you again what those findings are that we found for this year, and hopefully this will help you as you prepare again for the following marketing season. So last year we streamed the marketing guidelines, streamlined them, and we implemented 3 guiding principles. And we want to kind of reiterate this again because it's important that plans sort of follow this as they begin their marketing activities throughout the year. It's also important that if you have questions and when you're in doubt, you closely work with your marketing reviewers or your account managers. So the first one I want to talk about is documentation of compliance. And plans must ensure that they have some type of system in place documenting compliance, documenting any type of policies or procedures that you have in place for your sales activities or any of your operations. Oversight and compliance is another guiding principle. It's important that you have some type of oversight of your third-party or delegate entities. Regardless of what takes place out in the marketplace, we always look to you when there are issues or problems or concerns. When we receive complaints for beneficiaries, we call on the plan to ensure that they have proper oversight of any marketing activities or any other operations that are being performed on behalf of the plan. And the last one is accurately disclosing benefit information to beneficiaries. There has to be some type of quality control mechanisms in place to ensure that prior to submitting those marketing materials, they've been checked, and they are accurate, and they align with the benefits that you are to offer for the new contract year. I'm going to move on and make a couple of clarifications, talk about a couple of clarifications, and this is based on the feedback that we've received based on our guideline requirement changes. So this year, making revisions, we did change the requirements to the material ID, and our goal was to ensure that when plans submitted marketing materials, those materials received an approval before they were made final. Realizing that, what we did was we clarified, and hopefully some of you were able to receive that information, we clarified that file and use materials may have the term accepted on the material when they're submitting them. So we just wanted to make that clarification with the difference between being approved and accepted. So file and use materials are excluded from that requirement. I want to touch a little bit on advertisements. Throughout the year, we have conducted various surveillance activities, and one of them includes pulling advertisements, and Christine will talk about that a little later in her presentation. But advertisements are not excluded from the material ID requirement, not unless it's specified by CMS. So again, that's another quality control issue when you're submitting your marketing materials. You need to make sure that they have a material ID. We certainly use those, as you know, for tracking purposes. So I want to touch on the disclaimer requirements because this is another area that we received a lot of feedback. Each year we try to fine-tune this area in order to align with our regulatory requirements. This year we did not make any significant changes except for the federal contracting statement where we stated that plans, we added a second sentence to it, and we stated that plans needed to add that sentence ensuring that in order to enroll, that plan had to have a contract with CMS. With that said, we're allowing plans some flexibility in making sure that those changes are implemented. So plans have until the end of December 31st, meaning January the 1st, any mailings that are going out should have those new disclaimer requirements for the federal contracting statement implemented. Now the SB disclaimer the SB doesn't require a disclaimer update because the message is already included in the document. Where there are model documents or standardized documents that currently don't capture the revised disclaimer requirements, we ask that you do add those. If those are the only disclaimers that you will be adding, you'll still receive a 10-day or a 45-day review. So again, when you're updating these documents and making revisions, work closely with your marketing reviewers. Mailing requirements. We continue to receive questions on the mailing statements. Although this is not a new requirement, I want to make some additional clarifications here. We've received questions as to where the logo and the plan name must be placed. It can be placed either on the front of the window or on the envelope. It should be in 12-point font or higher. Again, this means that if a plan puts the plan name and the logo through the window, it should be large enough where the beneficiary can identify who it's coming from. If you're considering putting additional information on the envelopes, it must be submitted for review for a 45-day review. So now I want to get into the AEP marketing requirements, what can actually be done prior to October 1st. Each year, we are asked this question: what's permissible, what's not permissible. Of course, as you know, plans may conduct educational events. Educational does not include solicitation of marketing materials or enrollment forms. You can also conduct your own member-only events. And again, those should be advertised as such. It should be advertised as an educational event. And I just want to make another note about member-only events is that, again, there's no solicitation of enrollment forms. So no enrollments can be taken during that event. Prohibited activities prior to October 1st. We get a lot of questions. We understand that a lot of plans are gearing up. They're trying to send out information for their sales events, but that is considered marketing. So if you're trying to develop a postcard and you want to send it out to the beneficiary, informing them that you have a sales event starting October the 1st, that is prohibited. Any materials that will be discussing 2014 benefits, that is also prohibited. This excludes, however, the required documents such as the ANOC and the EOC. Again, when in doubt with any of these activities, contact your marketing reviewer. So this is another reminder for the 2014 upcoming season, what you need to keep on your marketing websites. So each year, plans need to make sure that they continue to keep current contract year information on the website until December 31st. Also, it's important that when beneficiaries are navigating through the websites, that they have immediate access to all required information. And what this means is that a beneficiary should not have to go through a third-party website in order to gain information on their pharmacy or their provider directory or summary of benefits. And the last slide I'm going to cover today are the website requirements continued, where we talk about social media events. Anytime that your social media events turns into a marketing or sales events, it must adhere to those requirements that we specify in Section 80 of the Medicare marketing guidelines. So with that said, that concludes my portion of the presentation, and Christine is going to start off with star ratings. Thank you.
Thanks, Camille. I'm going to talk a little bit about star ratings and requirements for this year so you can ensure that you use the proper star ratings at the appropriate time. We, as you know, release star ratings every October, generally mid-October, between the 10th and the 20th of October. You are required to use those updated star ratings within 15 days of CMS's release of those star ratings. So if we release them on October 10th, make sure, referencing star ratings, you have the proper and the updated star rating referenced as of October 20th, the CY14 star ratings. When you do work with star ratings and reference star ratings, we have a requirement that you always reference the highest plan rating. So if you are an MAPD plan, you need to reference your overall summary plan rating. If you want to go and reference things like a customer service or a quality measure or domain rating, you're permitted to do that, but you need to ensure that you have your highest star rating referenced. In an effort to ensure beneficiaries have full and accurate knowledge of exactly where a plan falls with CMS star ratings, if you happen to be a low-performing ICON plan, you also must, if you're going to reference your higher star ratings, you must be very clear and put the low performing icon indicator in there and reference that. For instance, it's possible if you are a Part C plan, if you're an MAPD plan, it is possible that you might have an overall star rating of, say, of 3.0. It is possible that you might be an LPI because your Part D summary rating is a 2.5, and it's been a 2.5 for a number of years. That would put you as a low-performing indicator, a low-performing plan. If you're going to reference that 3-star rating for the MAPD overall rating, you must clearly indicate your LPI status, so beneficiaries have full knowledge. Okay. Star ratings. We took a look at star ratings quite a bit this past year and how they were being utilized, how they were being advertised in our surveillance findings. We had a significant number of findings during surveillance. Almost 23% of our deficiencies this past year from the CY 2013 AEP were related to the star ratings. The primary problem we had was a failure to provide the star rating document with the enrollment application, and the MMG goes into the required documents when you provide an enrollment app, so please review that. We definitely want you to be in compliance with that. If you're going to provide that enrollment application, you're going to be required to provide the star rating document. That's extremely important for beneficiary choice. As Camille mentioned a minute ago, we also took a look at advertisements. As you might be aware, during the surveillance season, we clip advertisements out of newspapers to ensure that you're entering events into HPMS so we can secret shop those events. This year, what we also did is we took those advertisements and we started reviewing them for accuracy to ensure that they met MMG requirements. We looked at thousands of advertisements, almost 4,000 advertisements to look at these items. Some of the items a lot of plans are using the star ratings in their advertising. What we found is that it's not always easy to identify what star rating you are advertising. You might be saying you're a 4-star plan, and that's fine, but we'd like for you to clearly indicate that that's your overall rating. Otherwise, an organization, we want to make sure beneficiaries understand the highest star rating along with any other star ratings you're providing. So if you could more clearly indicate those in advertisements, that would be excellent for beneficiary review. Also, talking about advertisement reviews, we had a lot of plans were the highest rated in the area, were CMS highest rating. If you're going to make those statements, you need to ensure that they're documented. You need to ensure that the appropriate disclaimers are on your advertisements, and you need to verify that if you're going to state that you're the highest rated in the area, that is accurate and truthful. So you're going to have to do a review of other star ratings in that area to ensure that your organization does meet that standard that you are advertising. Camille talked a little bit about advertisement reviews also. Couple of things that we did while I'm on that topic, couple of things that we did find during the review of advertisements besides the star ratings. We found a number of organizations did not put HPMS IDs on those advertisements. As Camille said, that is a requirement. We are looking for that. We also found that there were disclaimers that were lacking. Most advertisements had disclaimers, but we do have a number of them that are required for different pieces of information. If you're going to provide certain pieces of information, you need to have the appropriate disclaimers. Our review this year came out with a number of organizations who were not compliant. We are currently in the process of reaching out to those organizations to let them know our findings. We are not taking compliance actions this year on items we found in advertisements, but we plan to do that for future years. So please, before you get everything to the newspapers, get everything printed, verify, double check, make sure that everything is accurate before publication. As you're all aware, we've done a lot of work with ANOC, EOC, timeliness, and accuracy over the past few years. Just a few reminders. ANOC EOCs are due into members' hands by September 30th. HPMS, you're required to enter the mail dates within 15 days of mailing. This is an extended time frame from last year. Last year, we provided you with 3 days after mailing to get those mail dates entered into HPMS. We've extended that to 15 days. We are checking HPMS to make sure you do provide the number of beneficiaries that have received the documents that you mailed and the dates that you mailed them. So if you don't put that information in, we'll be following up through your account managers. Accuracy, and this is part of one of the goals of that Camille mentioned, one of our principles, guiding principles, ensure quality reviews are conducted timely. We have looked at accuracy for a number of years. We continue to look at that. Each fall, we send, each late winter, early winter, we send out a reminder to plans to ensure that your ANOC EOCs are correct. Go do an additional retrospective review of that and submit changes to CMS via an errata sheet if there are inaccuracies. We find a number of plans who find inaccuracies in February, March, April, May, even into the summer months. It's not okay to find an inaccurate information in your ANOC or EOC in July of your contract year, especially when you've been notified to double check those items. Compliance actions with respect to timeliness. In the past years, we have required 100% compliance rate with timeliness. We have been reviewing our standards for timeliness, and we are making modifications on how we're going to issue, when we're going to issue compliance actions to organizations. We're not going to be requiring 100% threshold. We do recognize that there are times where you might just have a couple of beneficiaries that didn't receive documents timely. You have self-reported that information. We are going to acknowledge that it's there. We are setting a threshold for compliance timeliness. However, in the past, we have also given organizations a bit of a grace period. So although ANOC EOCs were due in beneficiary hands by September 30th of each year, we didn't consider organizations late until around October 14th. From now on, we're going to be looking at that date of September 30th. If documents aren't mailed by that date, you're going to be considered late. Again, we're going to take a look at the number of affected beneficiaries, compare that against the contract enrollment, and make determinations based on a CMS internally developed threshold. How many late documents will rise to a compliance action? We are also looking at decreasing the threshold for civil money penalty recommendations. MOAG is the group that issues the civil money penalties. MCAG, during our analysis, we provide referrals to MOAG. We will be looking at increasing the threshold for the number of beneficiaries affected for a CMP. So what that's going to amount to is that you're going to be allowed to have a few beneficiaries for which you will not get compliance actions for. If you have more beneficiaries, you'll be looking at a notice of noncompliance. At a certain point, we will be referring you for a CMP. In order to maintain flexibility, we are not publishing our exact standards. We do need to be able to account for when items are mailed, how many beneficiaries are affected. For example, if you have an organization that mails 1,000 members a late document and that is mailed on October 5th, and you only have 1,500 people in that particular organization, that is going to be looked at differently than if you mail a late document to all those 1,000 members and you mail that document on December 6th. AEP, as you know, runs from October 15th to December 7th. So we need to ensure these documents are in beneficiary hands, and the less time a member has to make a determination on whether to stay in your plan or not, the more harm or potential harm could be given to the beneficiary with timeliness. What did we do this past year on timeliness? On the positive note, we've been seeing over the years a decrease in the number of late ANOC EOCs. This year, we had 5 parent organizations with a total of 7 contracts that received NONCs for timeliness. So this is a decrease, and we do appreciate you making sure those documents get out on time. Compliance, ANOC EOC compliance with accuracy. In the past, we've always taken a look at ANOC EOC's compliance by using the errata sheets or self-reporting from organizations. We've asked you for numerous years to self-report it via Excel spreadsheets, Vovici tools. This particular year, we took a look at all the errata sheets that were entered in HPMS. We took a little bit different of approach this year. We focused primarily on benefit and cost-sharing issues. In the past, if your ANOC EOC was inaccurate, it was inaccurate. This year, we still noted inaccuracies, but we categorized them into benefit cost-sharing errors. We also looked at the number of errors for ANOC EOCs. Organizations that had one small error were looked at differently than an organization that may have had 18 minor errors. It gets to the point of accuracy, quality, really paying attention to the information that you're putting in those documents. We also looked at the positive, negative impact, and this is what I mean by that is how did it affect the beneficiary? If your original ANOC EOC informed the beneficiary that the premium was $50 and that was wrong, and your errata sheet said, sorry, it's not $50, it's really only $35 to the beneficiary, that was deemed a positive impact on the beneficiary. It was actually a lower cost to the beneficiary that they had originally thought it was going to be. Vice versa, if you had advertised in your ANOC, you had said your premium was $35 for CY13, and your errata sheet said, oops, it's really $60, that was a negative impact. That beneficiary may have made a different healthcare choice had they had the correct information. This year, when we took a look at accuracy for ANOC EOC compliance, like I said, we didn't take 100% threshold. In previous years, if it was inaccurate, you were issued an NONC. This year, we took a little different stance. Instead of just issuing NONCs, we also issued warning letters, caps, and we sent certain plans down for a referral to MOAG for a CMP. We took into account the factors I just said, the positive, negative impact, the number of errors that you had, and whether there were benefits or cost sharing that were affected. Giving you a perspective on how many items that how many compliance letters we issued 58 parent organizations received NONCs for a total of 90 contracts. We had 12 POs received warning letters that covered a total of 16 contracts, and we sent out ad hoc caps to 3 POs for 3 total contracts. As I said, certain organizations were referred for a CMP. That is still being reviewed at this point in time. If an organization was referred for a CMP and they are not issued one, we will be following up with the appropriate compliance action. Some of the errors, since you are currently hopefully doing the final reviews of ANOC EOCs, or you're in the midst of filling that information out into those documents, some of the things that we're finding to help you ensure accuracy this next year is copying and pasting. A number of your organizations, a number of you have a lot of plans. We believe from the information we took a look at is that you're doing a lot of copying and pasting from one PBP to another PBP, and the information is not always the same from one to another. So if that's the case, make sure you take each one individually and appropriately make the changes for each PBP. We had a lot of errors in the drug benefit, especially the coverage gap. That's mentioned, coverage gap, drug coverage, drug benefits mentioned a number of times in the EOC. Make sure you thoroughly go through that document when speaking about coverage gap and make sure that language is clear. Make sure you've got the correct information in all sections of your document. We had a lot of problems with inpatient this year, dental, vision, and outpatient services. So the takeaway from that is given the number of problems we had last year, make sure you pay attention to these 5 categories, but make sure you pay attention to everything else. So don't just look at these and ignore everything else. Make sure you do that review timely. Make sure you do an accurate review. When we do take a look at compliance, as I said, every fall, early winter, we ask that you take a look at your documents again in a retrospective review. We ask that you submit errata sheets. When we find that when CMS or your organization finds errors later in the year, well after we've asked you to report any changes or any inaccuracies, we're going to be issuing compliance notices, one on the inaccurate information using our thresholds and guidelines, and 2, we're also going to issue a compliance notice for your failure to properly oversee your organization and ensure your documents are accurate. Agent broker oversight. Again, with the AEP coming up, marketing beginning October 1st, please ensure all of your agents and brokers are familiar with the marketing requirements. There were changes this year. Make sure they're updated, make sure they're trained, make sure they're tested. Make sure they have the accurate information, and these are some just reminders. No aggressive marketing tactics. Make sure all of your materials are submitted and approved. Make sure the materials your agents are using, if they're developed, meet the CMS requirements and are submitted and approved if necessary. Compensation. About a month ago, we sent out a clarification for marketing, and along with that, we had compensation information. I just want to go over a couple of points on that. Reiterating that compensation must be paid on a calendar year basis, not an enrollment year. We found a number of organizations that they take the compensation, and if beneficiary enrolls effective August 1st, they pay the compensation from August 1st through July 31st of the following year. That is not meeting CMS requirements. If an enrollee is effective August 1st, the first year of compensation would be August 1st through December 31st. The new year would then start on January 1st through December 31st of the following year. Renewal payments must be prorated. We found a number of organizations who are not properly prorating renewal payments. If a person enrolls as a renewal enrollee, they are not an initial enrollee, they've been in a like plan before, any time that they enroll past January 1st, the renewal payment must be prorated, and it has to be prorated based upon the number of months left in the year. So if they enroll in effective February 1st, they should get paid 11/12 of the renewal amount. We have organizations who are paying a prorated amount, which is not the 11/12 or 5/12. It's their own calculated amount. We've got organizations who are paying the full renewal amount. Please ensure that the prorated amount is done appropriately. We're currently looking at organizations and how they're paying compensation. We are also developing a document that we're going to be asking organizations to fill out to get further information on how they are paying compensation. Our goals are to ensure that we have a level playing field for this coming season on the agent broker compensation level. We want all organizations to be treated equally and as fairly as possible. If you do expect you to go back and take a look at your compensation structure. If you are not meeting our requirements, we expect that you make any necessary changes as soon as possible, but we do expect that all 2014 enrollments and necessary changes be made in time for payments to be made for all 2014 enrollments. So if you're making payments during the AEP, those need to be made in compliant with our requirements. Retrospective reviews. We've started taking a look at some of our key documents on retrospective reviews, and we're going to continue with that. This past year, we looked at summary of benefits documents. We focused again on the benefits and costs with those reviews. A total of 230 SBs were pulled for review. 47% had no errors. Now, this is a standardized document that you're just required to fill in certain cost-sharing amounts. 53% of you guys had errors. That's a pretty significant amount of errors for a standardized document. 3% had major significant errors that we consider to be egregious that could have led to beneficiaries making a decision based on inaccurate information. 13% of these had less egregious but still quite serious benefits, cost-sharing benefit issues that could have led to beneficiaries making an appropriate decision based on incorrect information. The other percentage, which is about 36%, had either minor or major issues, but they weren't related to benefits and cost sharing. They may have been related to unapproved language, not implementing global hard copy changes. So with the SB review, we took a look at those that had beneficiary cost or benefit implications, and we issued 23 NONCs based on that. Following that review, we started to discuss doing retrospective reviews of ANOC EOCs, and we will be taking on a small limited sample this fall of ANOC EOCs to ensure that they're accurate. We'll be using the 2013 ANOC EOCs to get an idea of what we're looking at. In the early winter, we will be taking a larger sample of ANOC EOCs for a retrospective review. So again, this is an excellent reason for you to double check, triple check your documents, make sure they're accurate, because we will be looking at those and compliance actions will be issued for inaccurate documents. This past year, we also took a look at the outbound enrollment verification project. Your organizations submitted information to Impact, our contractor. First of all, I know it was a lot of work, a lot of resources. Thank you very much for submitting that information. We appreciate it. We have gotten the preliminary report from Impact, and what I want to do is just provide you with a few of the highlights. We are currently working on reviewing that report and coming up with final recommendations. But about 50% of the calls were completed. So out of the required 3 attempts, you only got a hold of beneficiaries about half the time. Primary reasons for incomplete calls were there were no answers or it hit voicemail. So you're probably finding that in your own organization. This is probably not a big surprise for you, but at least if that's what you're finding in your own organization, that's the average across all orgs. Timeliness of calls made. 92% of all the required calls were made within the 15-day time frame. We asked during this review about cancellations. We took a look at how many people canceled either during the OEV call or within a short time period after the OEV call. We do recognize that it is not a beneficiary canceling their enrollment following the OEV call cannot be attributed directly to that OEV call, but we took a look at that. We had less than a 1% cancellation rate for beneficiaries within those specified time frames. When we listened to the OEV calls, we also took a look at whether or not your customer service representative, the person making the phone call, was able to answer or refer the question for an answer. In previous audit findings, we had found that sometimes CSRs, a question was asked to the beneficiary and they didn't answer it or they didn't refer. So we've gotten a good improvement on this. So your people on the phone, your CSRs are able to either answer that call or get that beneficiary to the right person, either of which is an acceptable response. We took a look at the questions that were asked most, the topics. Prescription drugs are clearly the highest asked asked the most from beneficiaries. 31% of the questions that were asked during these OEV calls were about prescription drugs. Healthcare benefits, 16%, provider network, almost 13%, premiums, 2.4%, and the other category was just a bunch of miscellaneous calls which couldn't be categorized. For preparation for OEV this year, a couple of recommendations that we can provide from the report are we took a look at the best time frames. The vast majority of calls that were completed from 9 a.m. to 5 p.m. So if you're going to focus time frame, it's during the regular workday hours. 9 to 5 is the best time to call. When we took a look at whether calls were answered or referred, the two categories that were either answered, that were not answered, nor were they referred the most, were questions about prescription drugs and premium questions. Premium should be pretty easy questions to answer, so although it was a small percentage of questions asked, they were not answered a large number of times compared to the other questions. The other thing to take out of this is begin OEV calls as soon as possible. 92% of you did complete those calls within 15 days. The organizations that were not able to complete the 3 calls, they got started late. They may not have started until day 8, 9, or 10 of the 15-day time frame. So that is probably the reason why they did not complete all the calls. And you have our contacts. Please feel free and reach out to us if you have questions. And I'm not sure how much time we have for questions now. But if you have any, we're willing to take a couple.
I have a question. How many non-compliant letters are issued before more stringent actions are taken?
That's going to depend upon the issues. On our compliance, we have to take into account what was done, what was wrong, if the organization has been notified before, verbally or not in a compliance letter, we have to take the egregiousness of the action into account. So something that's extremely egregious may not start off, probably won't start with a notice of noncompliance. It might start off with something more stringent like a corrective action plan or potentially even a referral for some sort of enforcement action. So it's impossible to give a formula since it varies with the issues.
Thank you.
Do we have any more time? Okay, time for one more question.
Okay. Hi, Christine. This is Amy Schultz with Health Partners. And the information you provided on the ANOC and EOC timeliness and the accuracy was extremely helpful. And I'd just like to share a recommendation that, it would actually be more helpful if we had a little earlier, because it's already September and plans are beginning to mail their ANOCs and EOCs now, so they may have already submitted them to CMS in order to have time for print and fulfillment and that type of thing. But I think we'll all end up going back and just doing a quick retrospective review to ensure that these tips that you provided are used to the best of our abilities.
And I certainly understand that you've submitted the stuff. The accuracy is not a new requirement. Right. The timeliness is not new. Yeah. Go back, review it right now. If you find an error, contact your marketing reviewer, get something submitted, the correct information as soon as possible. If it has already been printed, take care of the errata sheets, put them in with the documents. So, just get the right information in the beneficiary's hands the first time.
Yep. And then I had a question also for Camille. I was a little bit confused on the clarification or the statements you had regarding the disclaimers for the contracting statement, specific to model documents. And it sounded like you're asking plans to add the statements to the document, where the slide made it sound like plans may. So I was just trying to understand.
They may add the statement to the document if it's not there, and it'll still be considered a model or a standardized document. You can still treat it that way.
So, for example, CMS is releasing the enrollment guidance for 2014, and if the model's not changing, that's in the exhibits, and the contracting statement is not there, are plans required to add the
They're
contracting
not required,
statement?
but we recommend that you put it on there so that the beneficiary has accurate and the most up-to-date information.
Okay, so just one more follow-up. So
Sure.
if a plan based a letter on a model, but they chose to go non-model, the model hasn't changed, is the plan required to submit their non-model letter again, even if the only change is a contracting statement?
We have to capture that information, the correct information, in HPMS, so it would have to be resubmitted because we have no way of tracking the correct document.
Okay, and then is RO staff ready to review the amount of documents that possibly could be submitted?
We recommend that you contact your RO reviewer and work with them because if it's the only thing that you're changing on the document, it should be a smooth process to go ahead and upload it and get it reviewed and approved.
Okay, thanks for the clarification.
Thank you very much, Christine and Camille. And we also thank everyone who actually participated in asking questions today. Again, if you do have additional questions, we do have a mailbox in which you can forward those questions to. It is cto@cms.hhs.gov. Let's go ahead and move on to our last session scheduled for this morning. We're going to actually introduce to you Susan Rankett. She has 15 years experience working with CMS and is from the Division of Policy, Planning, and Analysis, which focuses on Medicare Advantage and Special Needs Plan, Policy and Quality Improvement Program projects. Suzanne will provide you with the information on updates to Chapter 16B in the Medicare Managed Care Manual, focusing on revised policy and operational guidance. Please welcome Suzanne Rankett.
Good morning, everyone. I know that you're probably very anxious to get out of here and on to lunch, so I will do my best to be speedy, and we'll go through Chapter 16B. Welcome to everyone who's here in the audience, and for those of you on the webinar, thank you for joining us. The purpose of the presentation today is to discuss Chapter 16B and the updates and revisions that have been made to the chapter. I also want to give you a heads up. Along with Chapter 16B, DPAP is currently updating the quality chapter, which is Chapter 5. We are hoping that we can be able to get Chapter 5 out to you soon as well. But for purposes of our discussion today, we will solely be talking about Chapter 16B, and also later in the presentation, we will be talking about the revised models of care. Chapter 16B, as you know, provides current interpretation of statute and regulation that apply to Medicare Advantage organizations that offer special needs plans. Chapter 16B was updated to reflect all the guidance that is depicted in the April 2nd, 2012 and the April 1st, 2013 Medicare Advantage capitation rates and Medicare Advantage and Part D payment policies and final call letter. We are very interested in your input and your comments on the revisions to the chapter, and we are soliciting any questions or comments that you may have. Presently, Chapter 16B is going to be released, we are hoping today, so that you will be able to see in the HPMS memo and in which will have a link to the chapter, which I have here. Also with that, you will have an Excel template. So what you will need to do in order to provide comments to CMS is to, of course, read the chapter thoroughly. You will notice any changes or any revisions in red. It will be bolded red and italicized. Please put your comments on the Excel template, and then you can send those comments to me at susan.ratke@cms.hhs.gov by September 20th. If for some reason the chapter does not get out today or tomorrow, then of course we will extend the comment period. There are 10 updates in Chapter 16B that I'd like to highlight during this presentation. The first one that I'd like to highlight is Section 30, the applying the frailty adjustment to the fully integrated dual eligible FIDE SNPs. Section 30 in the chapter deals with payment and payment methodology to SNP. In terms of the dual eligible FIDE SNPs, Section 30.2 clarifies the application of the frailty adjustment to FIDE SNPs. It also updates the chapter to reflect guidance that was outlined in the April 2nd, 2012 call letter regarding long-term care carve-outs. So you will notice as you go through your review in Chapter 16B that we've really consolidated all the information that we've been providing for you for the last 2 years, and we've also provided some new guidance. The next section that I'd like to highlight is Section 40. Section 40 in the chapter deals with the application and the approval processes for special needs plans. Specifically in this section, we have revised Section 40.2, which talks about the model of care cure process, which involves the NCQ approval. The updates current model of care cure process that is consistent with the April 2nd, 2012 call letter. And it also highlights that now there is only one cure opportunity for the special needs plans. I am not talking about MMPs, just special needs plans. So please make a note of that. Also in Section 40, we've updated Section 40.3, which talks about the existing SNP model of care reapproval and application submissions. An MAO with an existing special need plan must submit only a model of care in HPMS when its approval period expires. So I want to make sure you understand that you need to know your approval period and your date of expiration period for your model of care. HPMS does not have the capability at this time to provide you with an email that says, hey, your model of care is due, you need to reapprove. You need to be able to know your approval period and at that time go into HPMS to see if the mock module is there so that you only need to submit that model of care. This doesn't pertain to a service area expansion or if you're going to go ahead and decide to apply for a new SNP. Section 40.4.2 discusses the initial application and service area requirements for DSNPs. This section highlights that the service area in a DSNP must match the service area in the state Medicaid contract. Again, we also clarify the FIDE SNP definition at 40.4.3 that updates and clarifies the definition to include specific long-term care carve-out or exclusion criteria. So you will see that in the Chapter 16B. The next section in this application piece discusses the benefit flexibility for certain dual eligible special need plans. It adds guidance on benefit flexibilities, again, as detailed in the April 2nd, 2012 call letter. It also clarifies the minimum contract performance and quality requirements. We also list the types and categories of benefits that CMS may approve under the benefit flexibility, which is in section 40.4.5. We clarify the need to include these additional Medicare supplemental benefits in the plan benefit package. We highlight the need to attest that benefits are not duplicative of services under a waiver, a state plan, Medicare Parts A and B, or under the local jurisdiction. Additionally, we provide examples in chart form of the additional benefits that may be offered, and you will see that it's basically a cut and paste from the call letter. The next section, Section 50, deals with eligibility requirements for SNPs. We wanted to update this section, especially verification of eligibility for C-SNPs. This section limits the options for eligibility verification and clarifies the chronic condition verification process. When we were reading Chapter 16B, we here at CMS became confused with this language. So we wanted to make sure that we could clarify this so that it made sense for you. So what we did was that we clarified the section so that MAOs are expected to verify their chronic conditions with the existing provider prior to enrollment. The MAO may use a CMS-improved pre-enrollment qualification assessment tool if you are unable to obtain immediate confirmation of qualifying chronic conditions, but you must obtain verification within the first month of enrollment. The vast majority of MAOs have been able to verify potential C-SNP enrollees' chronic conditions prior to enrollment. We took a look at all the MAOs out there and found that only one or two used the expanded alternative verification methodology. Very, very few. And we found out that since most MAOs are able to verify prior to enrollment, we removed the expanded alternative verification methodology. The next section, 50.2.1, is an added section. While we were reviewing Chapter 16B, we wanted to make sure that it was very consistent with Chapter 2 in the Medicare Managed Care Manual that specifically deals with eligibility enrollment. Chapter 2 discusses C-SNP eligibility, D-SNP eligibility, and I-SNP eligibility. Therefore, we decided that it would be best if we were consistent with that format, and we added guidance consistent with policies in Chapter 2 of the Medicare Managed Care Manual. Section 50.3 deals with the waivers to enroll individuals with ESRD. This part of the chapter provides guidance on how to request a waiver to enroll individuals in ESRD. It requires an upload document as part of the application, and it requires a description of how the applicant will monitor and serve the needs of the ESRD enrollees, including care coordination. It goes into detail about further requirements that a health plan needs to adhere to in order to obtain this waiver. Again, section 50.4 talks about the continued eligibility requirements when a beneficiary loses their special needs status. It clarifies the continued eligibility requirements that apply to DSNPs. And I want to make sure that I have my right notes for this one. CMS updated and clarified deemed continued eligibility for DSNPs due to confusion around payment of Medicare premiums and cost sharing once a beneficiary loses Medicaid eligibility. So a particular part of the section really is devoted to those beneficiaries who lose their Medicaid status. It clarifies that during the period of eligibility, a DSNP must continue to provide all Medicare Advantage benefits that is approved in the plan bid for at least one full calendar month or up to 6 months for a member who no longer has special needs status. So the chapter clarifies that during the period of ineligibility, DSNPs are not responsible for providing Medicaid benefits. DSNPs are not responsible for the state's share of Medicare premiums or cost sharing. So we hope that this clarification has been helpful for those MAOs that are offering a DSNP. Section 70 specifically talks about marketing. And under 70.1.1, we discuss the marketing exceptions for DSNPs. DSNPs may choose to send the annual notice of change, or the ANOC, and the summary of benefits for member receipt by September 30th, and the evidence of coverage for receipt by December 31st. Or the ANOC or EOC together for member receipt by September 30th, in which case you're not required to send the summary of benefits to current members. The next section, 90. Now, just giving you a heads up, please don't have a coronary. When you get to section 90, it's not going to be there. So have no fear, we have not gotten rid of the models of care. As you know, we have revised the models of care, and we are now compiling your comments. And in advance, I want to thank you for all your comments. We have not received them yet. They are on their way to CMS. We will be compiling them and sorting them, reviewing them, and we will be responding to your comments. But as of now, the models of care are not included in Chapter 16B update pending these revisions. But we do want to talk about the proposed revisions of the model of care this morning. We have 4 elements. The 4 elements that we have proposed are the description of the SNP population, care coordination, the SNP provider network, quality measurement, and performance improvement. Like I said, as you know, the PRA package comment period closed last week, August 28th. And as I said previously, we are now compiling all the comments. We have proposed to reduce the number of elements from 11 to 4. The 4 elements capture all the information collected in the current 11 elements. So it's really a restructuring of the models of care. It organizes information from interrelated elements in a more concise and cohesive manner. The integration of the related elements promotes clarity and enhances the focus on care needs and activities. Care coordination element includes care transitions which are not explicitly captured in the current elements. I just want to remind you that once we receive your comments and we make our revisions, we will finalize the model of care, and it will be applicable for the CY 2015 application. There will be training for the special needs plans on the revised model of care prior to the application submission. So we're hoping to do that in some time in January or right before you are able to submit your application. With that, I've come to a conclusion, and I'm hoping that this chapter you'll find will be easier for you to read and comprehend. And I don't know if you have any questions at this time, but I'm willing to take them. I'm sure your stomachs are grumbling and you're ready to take a rest. So are there any questions?
Thank you. I had a couple of questions. One on the CY 2015. If you're currently under a 3-year approval, will you still have to resubmit under the new structure?
No.
Okay.
Not at this
So
time.
if you had a year left, you could delay for a year.
Yes, that is correct.
The other question I had was about the benefits and the waiver. If you wanted to put additional benefits because maybe only 10% of your population is waiver or whatever, that would stack, is that allowable, or do you have to exclude that if any part of your population would have that benefit available under their waiver program?
Are you talking, what type of a waiver are you talking about? ESRD, or are you talking about a state Medicaid agency waiver?
Right, a Title 19, like a home and community-based waiver program.
If you could send me that question directly, then I'll look into that for you.
Okay.
And let me go back. It's susan.radke@cms.hhs.gov.
Okay.
I'd appreciate that.
Thank you.
There we go.
Okay.
Hi, Susan. Thank you for the presentation. Richard Popper with DST Health Solutions. This may not be your area, but since you're describing SNPs, I'm asking this question. In 2013, SNPs were required to have some kind of contract with the state Medicaid agency, and I'm just wondering, is there any modifications to that requirement that you're aware of? And if also you could discuss the range of contract relationships that SNPs reported to you in terms of the range of relationships they had with state Medicaid agencies that CMS reviewed and looked at.
Well, I can tell you definitely that all DSNPs are still required to have a CMS-approved state Medicaid agency contract, and that nothing has changed in terms of that. I don't know what the range is because I'm no longer working in the DeMayo division, but you can always ask that question specifically to the SNP mailbox, which would be snip_mail@cms.hhs.gov.
Okay, thank you.
Does that help?
It moves me along, thanks.
Okay. Are there any other questions about Chapter 16B updates? Great. Well, I hope you have a very good lunch and you get rested and enjoy the beautiful day outside. Thank you so much.
Thank you, everyone. At this time, we are actually going to break for a 1-hour lunch. We will resume the conference once again at 1:15 Eastern Standard Daylight Savings Time. For those visiting us here on site today, there is a cafeteria located on the lower level of the building, so please, we do encourage you to check that out. In addition, there's also an ATM machine should anyone need that as well. Thank you again, everyone, for joining us this morning. We will resume once again at 1:15.